And then I'll show you, there, again, two residents did the diabetes study here in the San Francisco jail, looking at the age-recommended or appropriate disease-recommended screening, and another resident did the cancer screening. We talked to all men over 50 and all the women about pap smears and colonoscopies, and looked at where they got those, and overwhelmingly the women were getting it in the jail. So they were up to date with pap smears, but because they work in the jail, yeah.
I'm just curious, like, how open are the prison administrators to having researchers come in and do these
Yeah,
things?
so let's switch that here, like completely the lead-in. Here's these examples. So we did all these TB preventions. We randomized people to different ways to get you linked to care. So you're, again, it's good we have it up there twice because we did a lot. There's a lot of good projects with, you got screened and got started in the jail, but then you don't go, so, you know, the first thing we did was a chart review, and we saw that only 3% of people that got started on INH in the jail ended up coming to the most common place most of them would have come was the TB clinic to continue. So like, what was the point of all that screening and getting them through 2 months of meds if they don't get any linkage to care? So we did this, and we showed the jail, this was the beginning of making a relationship with the jail health service program here. And you're asking the absolute right question of any new investigator is, you know, do they want me doing these projects in this setting, whether it's in the emergency room or whether it's in a jail or a hospital floor? You definitely need partnerships with the site that you're practicing at in order to be open to it. And it's clear that the local county jail, where you know, Joe Goldenson comes over to see his patients at San Francisco General, he's the head of the jail health services, you can make friends with him, you can ask them about what they're interested in doing, and they become your important partners. So when they saw this data, they're like, what the heck? I mean, they were happy they weren't letting anybody develop active TB in jail while they were on INH, but it didn't really do that much good from a point of view of like public health service, which is what they really wanted to do. So we did these randomized trials, we offered you cash, not cash. The jail, the sheriff in the jail, very interesting, your comment about how open were they. When we started presenting the idea of doing a study, particular studies, they were like, that's fine, but I want our people to get the same thing they would get on the outside. So I've had people come in and offer to do studies, but they put like candy in their discharge packets, and I don't want that. If you would pay $10 for an interview, I want these guys to get $10 put on their book. So it was a very enlightened approach to being equitable, whether you were inside or outside as a research participant, and that came from the jail folks themselves. So we did this stuff about could we follow people into the community after they were released. The answer is if you offer to pay people, yes you can. I mean, it's a job, you know. I think participating in projects are jobs, and I like my job, but if I didn't get paid, I probably wouldn't show up every day. So the cancer screening, I just wanted to show you that. The cancer screening one was fun because what we just said, we wanted a snapshot of everybody in the jail in a short period of time to try to be like as thorough as possible. So we ended up, and people are moving all the time, they're getting released or being brought in. So we picked a holiday weekend, and Ingrid got, in fact, was she in your cohort? She like pulled in every favor from every resident, friend, some outreach workers that had worked with some of her patients. We trained up like a dozen people. The sheriff let all the deputies know that this Saturday, Sunday, Monday, some different things were going to be happening. And we went in and just blanketed, so we were in there for like 8 hours. We had to leave during count. Like there's all these things you would know. You don't have to leave the hospital or leave the clinic except when it closes, but in a jail or prison, when they lock down to count, make sure everybody's there, everybody else has to be out of the way. So we would, you know, go have lunch and then come back. And we ended up doing something like 150 interviews with people about their cancer screenings in just like this rapid fire approach. And the other big thing is you had to have both the jail health services people had to be supportive, and the deputies had to be supportive because one of the big IRB rules, and we'll talk about this more a little bit, is you cannot approach people directly. I mean, that's a kind of general Committee on Human Research, Institutional Review Board rule. It's like people, you can put up flyers and they can contact you, or you can go to a clinic but it should be clear that you're not coercing people and attacking them while they're in the waiting room. It should really be that, you know, someone has said, oh, there's researchers here and they may be talking to you, and if you don't want to talk to them, just let us know and we'll send them away. In the jail, it's even more strict. They really have to either tell the jail health services people, yeah, I don't mind coming and talk to people, or tell the deputies. And the deputies all agreed to be very cool about it. Just like, it's a health screening questionnaire. You don't have to do it. We don't mind. Your name's here. We'll just cross your name off and tell them they saw everybody that they could see. So that cooperation and protection of identity was a big part of doing the projects. So then we went on to do things like randomized trial of self-administered antiretrovirals versus directly observed therapy given by the nurses. And we were interested then in what happened after you left. Like, did you habituate to taking your meds if you took them on your own in a way that you didn't if you were given them like you were in the hospital. And we looked at we're now actually active project with folks at CAPS is looking at 2 different styles of case management where people really become your like best friend or big brother and try to keep you out of jail as well as keep you connected to your appointments. And then this, you mentioned about the educational one, which was great because we just finished with a couple of medical students doing a pre-evaluation of how much do you know about post-exposure prophylaxis, when would you take it, what are the high-risk behaviors, how would you get it. And they did a 15-minute educational session about PEP. And then they did, at the end of the session and 1 week later, another follow-up study, a follow-up survey just to see, okay, do they really even learn it in a 15-minute session? Do they hold on to it? And does it change anything about, you know, how they would perceive themselves? So those are all projects that were just done in the last couple of years. All right, so special challenges, kind of, you brought up one of them, the idea of, well, I guess that's the next slide. I brought up one of them about the extra layer of subject protection, about really making sure it's okay for people to not be involved in a project and not feel, A, that they're going to get extra favors, and B, that they're going to get extra punishment if they don't participate. So that's and any testing studies you do, like HIV testing in the jail, for many, many years now, even before it was required reporting by the state, you know, now it's all named-based reporting for HIV testing, or I don't know if you know that. It was that way in the jail for a very long time. The sheriff, the jail health senior physician, and the sheriff would be told if anybody tested HIV positive in the jail. They didn't do special lockup here, but there are many facilities around the country where once you're identified HIV, you're going to be in a certain place, you're not going to be allowed to do certain work, you'll be handled in a different way. So people had to really be clear that if they said yes to this project, there might be consequences independent of the study on their life in prison or jail. And then the whole mission thing is really a big issue because obviously, you know, in an academic university hospital, there's a kind of overlap of mission of healthcare and discovering new, true things about, you know, new drugs and health. In a jail or prison, the missions are really divergent, right? It's about keeping people locked up, keeping people safe, and whereas yours is like, I want to have people not go back in, and I want them to be healthier while they're here, and I want to understand why it is somebody might be at risk for being sexually assaulted while they're in jail. So very much divergent issues that you have to sort of realize you're in the middle of an island while you're trying to do the research. And you have to be very respectful of the security folks that their life is there. You come in and you leave, you find out your things about, oh, how they're the reasons people are getting sexually assaulted, and then you leave and they're still left working there and the inmates are still left being there. So really walking these lines, and then anybody have an idea what blurring the lines between protecting participants and colluding in security breaches means? Bringing in little spoons to dig the tunnel. No. So when you do surveys, and if you're doing surveys of HIV and HIV risk and prevention, what are the kind of questions you're asking about?
Like drug use and
Like
sexual practices.
Exactly. So the very stuff that's actually a felony. So what do? Can you get permission to not show the data to the jail, the prison authorities? But if someone reports to you that they're being sexually assaulted by their cellmate, you report that in the same way you would report sexual assault if you were out in the community. So you don't want to tell on them if something illegal is happening, but you also don't want to leave them victimized. So it's often this very delicate balance between being protective and being able to do honest research. And there's an issue of staff safety. I mean, we'd be foolish not to say that you have to think about the safety issues for people that are doing the projects in prison and jail. And then relationship between investigators and the leadership. And so that's really your comment and question, which I think the jail health services here, they were like ideal partners. I'm sorry, I didn't realize this came in chunks. We realized they would be ideal partners because, like, first of all, they were doing this TB screening. That's how it even came up. I sat in on a TB annual report, and they talked about all the hundreds of people they had screened in the jail and put on medications, and I thought, wow, that's kind of interesting that they're even willing to do that. And number two, it turns out they had a vision statement about where they saw themselves fitting into the community and how they really felt like the jail health medical director felt like these guys, this is just another big clinic as far as I'm concerned. They could be at Tom Waddell, they could be at Mount Zion, but this week they happen to be in my 850 Bryant clinic, and I want them to get the same care they would get if they were with you somewhere else. So that kind of forward thinking. But what surprises me is it turns out there's a lot more of that forward thinking. You just have to look for it in people, the people that are often working in jails and prisons. You know, some of it is a difficult, I'm so sorry, I should have taken this animation off. Some of them, there's difficult relationships, but a lot of them are there because it seemed like the right thing to do. It seemed like a population they would be really interested in. And so this whole thing about building trust and respect, which is something that's going to happen in all your projects if you're doing them in any kind of field setting rather than lab setting. And even in lab setting, it's trust among co-investigators that you're all watching out for each other. But you have to have, the jail had to be willing to hear about poor outcomes. If the studies had shown that the diabetes care was horrible, they had to be prepared, and they said they were. Like, they would not alter our manuscripts. They wanted this stuff to be reported out. They wanted to be able to understand why it was poor. So their main thing is, like, be willing to talk us through what you're finding and why you find it. And then this relationship, like them or not, I think the hardest stuff was more like at San Quentin, where the guards really kind of run their own deal there, and it is really an alternate universe as opposed to the jail where you kind of more easily come in and out. But at San Quentin, there really was this feeling that, like it or not, you wanted to be respectful to the security guards, partially because of what I said, that, you know, they're still there when you leave, but also because you don't get anybody brought down to see you without the support and the involvement of the security staff. And then there was always a big thing of, like, it can't make any more work for us. Like, so I can't have the nurses be doing extra stuff because of your study. And I think you'll hear that in a lot of different projects. In this last, so I was just going to touch on history, but only in general ways, because I don't know if you'll do a more detail. Certainly all of you, when you've done your CITI training, I think it's called, where you really go through the history of research on different populations. And, you know, frankly, the whole picture is pretty ugly. And if it's ugly with poor, impoverished people, just add by 10 what it's been like for prisoners, given sort of the attitudes we've had about the people that we decide to lock up. There's lots of different regulations at the federal, even there's some at the state level, but luckily the state stuff is all very much equal to what the feds are. So the feds is the highest level of requirement, and if you meet those, you're going to meet most of the state requirements. And the one thing, if you walked out of here with, like, okay, one bit of information about Committee on Human Research and prisoners, the main issue is around confinement. So people that are on parole and out in the community, we were saying, yeah, they have to check in with their parole officers. They don't strictly fall under this requirement to have special evaluation of your project by your local institutional review board. But if they end up back in jail, you better have had it approved by a committee that's got a prisoner rep on the committee. So it's when you're in a place where you couldn't say no, or you couldn't get out, you couldn't necessarily make contact with others, that's the group of people that the prisoner oversight regulations are really meant to protect. So here's San Quentin, and I was gonna do a quickie thing of like, okay, who is are they subject to this Part C for prisoner care if they're at San Quentin? That seems pretty obvious. If they're held at 850 Bryant, even though they may be innocent, but they're held at 850 Bryant, do they count as needing special protection? Right, I'm seeing heads nod. What about the release to the community but on parole? Just saying, do you have to have special prisoner permission to work with them? Yeah, so the answer is no, as long as they stay out. Court mandated drug program? It's actually gray zone. You can't really leave the drug program. So that you are essentially confined, just not in a jail or prison. So any projects that go on there does need to have the special committee look at that research. And then if you're already, I enrolled you in my ED study and you were just a free citizen, but then you get stuck in jail and I want to do my follow-up interview and blood test, would you have had to, did you get an exemption because you enrolled them as a free living citizen? What would you guess? You would be guessing right, that's right. So as soon as they are arrested, even though they started out free, if they're black, good job, yeah, 50 points. And then the thing I want to say is like, you know, it makes sense because people don't have their choices. And this will be my last slide, is I know it sounds so onerous to have like, oh, as if the IRB is not onerous enough here. This is the slide I was going to show you for IRB stuff. You got your idea, you got your funding, and then you have to apply to the IRB. So I know it can be very, very intimidating, but the truth is that it's just like one extra layer where we have the committee at San Francisco General where we have a prisoner rep. And it could be actually a former prisoner, but in our case we have a lawyer that tends to do, their group does a lot of pro bono work. So they're really meant to have the care and watch out for the best interests of the inmate. So you just need to apply to that particular committee. And then unfortunately that committee, once they approve your stuff, it does have to go to the feds and it gets published in the Federal Register of Intent. But mostly it's just waiting. Almost once it's been approved by us, and you do have to wait a long time, but you know, they tell you give yourself an extra month if you've got prisoner-related research. And the truth is, if you're going to have drug studies or projects where people are going to go back in and out, we were saying if they're going to end up, depending on who you're studying, you do want to go ahead and do that extra step right up front and say have it reviewed by the prisoners, because like youth studies or juvenile stuff where there may be issues around juvenile delinquency, if they're going to be back in and you can't get your follow-up data, and once you have your approval, you can definitely go into the jail and work with the jail health people. So I should stop there. Any other questions or comments in like the last 30 seconds before you get a little break? Yeah.
How accessible is the female population?
So the female population, so it depends on whether you're going to try to jail or prison. For prisons, the closest female prison is in Dublin, California. So they're separate institutions. There's some states that are so small that the women and the men are all in the same place. For San Francisco, all the women are at 850 Bryant. They have more programming, educational program support stuff than the men. And I can tell you that group, the program support people there are 100% enthusiastic about research projects, especially if there's this thought that it might benefit people. So like the PEP project, they love that because they knew the women. I mean, the interesting stuff that came out of that study is the women are all, like 60% of them are doing very, very high risk behaviors, and only about 20% of them think they're at risk for HIV. So they completely disconnect behavior from risk assessment. They were all very interested in PEP. Almost nobody knew about PEP. So you would get a lot of support for projects like that are going to like really support the women. Yeah. I should stop, huh?
Yeah. Well, that's fun though, but thanks so much.
Yeah, you're very welcome.